Good afternoon and good evening. Welcome everyone and thank you for joining today's Concord Talk. And I'm very happy to see so many of you attending this first Concord Talk in 2025. My name is Arjan Rotink and I am the founder and CEO of Concord Neonatal. And I'm really delighted to announce today's speaker, the inventor of Concord, Professor Arjan. Today, Arjan will present his learnings of over 10 years ABC project and share the latest evidence of the recently published ABC3 trial. Today is really special for me personally, but also a major milestone for Concord Neonatal, because this ABC project was one of the main reasons to found Concord Neonatal, now almost 8 years ago, to enable this important work of Arjan. And I'm also very grateful that we can provide this platform for you today to discuss the results of this work together with all of you after so many years of dedicated effort by so many people, and many of them maybe also in this call. So thank you very much. Arjan will have a presentation of about 30 minutes, followed by 25 minutes of discussion and questions, any question that you may ask and want to ask. And please also note that this session is recorded and you will all receive a recording of this session afterwards. Although many of you know Arjan, I would still like to announce and introduce him. Arjan is a neonatologist and a professor of perinatal transition and neonatal resuscitation from Leiden University Medical Center. His main focus is to expand the knowledge of perinatal transition and to develop the best strategies for neonatal resuscitation. Arjan is the initiator and leader of the ABC project, and he is the inventor of physiological-based cord clamping with the Concord birth trolley. So thank you very much, Arjan, for providing today's talk, and welcome.
Thank you, Rihanna. I will now share screen.
Yes, perfect, it works.
It works, okay. Hang on, skip me 1 minute. Yep, there we go. So now I can see you all. Well, thank you, Rihanna, for inviting me and also for introducing me. And indeed, what I would like to do in the next 30 minutes is to talk about the lessons we actually learned from the ABC project, the aeration, breathing, and then clamping project. And it's a project indeed of 10 years where all kind of disciplines and a lot of collaborators have been involved. So I might be the initiator, but you can't do it without the help of everyone. And it has been a huge experience. And on the road, we have many lessons that we learned. And that's the one, or these are the ones I would like to discuss it with you. First, about the rationale, why, what are the potential benefits of waiting with clamping? Well, the first of all, of course, that's you're all familiar with, is the placenta transfusion. I placed it between brackets because we're not sure if it's really a transfusion. It's more like a rebalancing of blood that's in the placenta and the baby. There's no doubt there is a placenta transfusion, or there is blood going from the placenta to the fetus if you wait with cord clamping. That's why you also have an increase of birth weight, for example. But the mechanism, there's been a lot of extrapolation and assumptions made. But so far, we actually don't know very well what the mechanism is behind this placental transfusion. It has been suggested that the contraction of the uterus, but as soon as the uterus contracts, then actually the whole perfusion of the placenta stops. So nothing comes in and nothing comes out. And also the gravity has been shown in experimental, but also in clinical studies that that's not the case, that influences the placenta transfusion. The only thing that still stands is the breathing effort of the baby. Observational studies performed here in Leiden has shown actually that during inspiration, there's a negative pressure and the contraction of the diaphragm causes a preferential blood flow from coming from the ductus venosus instead of the vena cava inferior. And that might be that there's a contributing factor for the placenta transfusion. So that's also then tells us actually that it's better to wait until the baby starts to breathe or is breathing before you clamp the cord. Then later on, of course, the other might, perhaps the more potential benefit is that if you wait with until the lungs are aerated, and the left part of the heart is more dependent on what's coming from the lungs than from the placenta, it might be that you sustain cardiac output. You don't get a sudden decrease in venous return. But this tells us both that actually the lung aeration, the pulmonary transition, but also circulatory transition are very linked to each other, intricately linked. But just to show that that was the hypothesis, that it's better to wait with cord clamping to sustain cardiac output, but we still had to show it. So we started off with experimental studies with lambs, preterm lambs. And this is, you see 4 figures. On the left top part, the heart rate. On the bottom left, the right ventricular output. And on the right side, you get carotid arterial pressure and flow. And we actually compared where we clamped first and then ventilated preterm lambs, or that we first ventilated the preterm lambs and then clamped the cord. And as you see, the red line is the ones where they clamped first and then we ventilated the lambs. And as you can see, the heart rate drops, it becomes bradycardic, the right ventricular output drops and then increases again as soon as you start to ventilate. And the carotid arterial pressure and the carotid arterial flow, you get first an increase, then a decrease, and then an increase. So this can be explained by, as soon as you clamp the cord, there's a decrease in venous return and an increase of systemic vascular resistance, which causes actually the decrease in heart rate and decrease in cardiac output. But as soon as you ventilate, then the pulmonary blood flow increases in the left part of the heart is more dependent what's coming from the lungs than from the placenta, and you get a restoration of the heart rate and the ventricular output. The carotid arterial pressure, so it's biphasic. First you get an increase, then a decrease, followed by an increase. That can be explained by the increase is actually that as soon as you cut the cord, you're missing out the low systemic resistance of the placenta. So you can increase of systemic resistance, you can increase of pressure, and then you're missing out your cardiac output. You get a decrease in pressure and flow. And then as soon as you start to ventilate and you have lung aeration, that's the trigger for increase of pulmonary blood flow, you get a restoration with that. So this has been shown, but also in animals, in lamb studies, we also shown that it's not only that you get a better circulation, but also better systemic and cerebral circulation and a better oxygenation, cerebral and systemic. So the experimental studies actually showed that, that it has a benefit, and it might be worth to look more into it and see if we can translate these results into the clinic. Well, the first question we ask ourselves, do we actually need a table to translate this to the clinic? Well, if we wouldn't do it, then we would ignore all the research we've been done in the last 15 years about stabilization of the preterm infant. It's not that easy as we think. It's a very subtle and narrow therapeutic margin where we effectively support the baby. We have to deal with mask leak, obstruction. If you flex or overextend the neck a little bit, you already get obstruction. Of course, you get the obstruction because the larynx is closed still in the fetal function unless the baby's breathing. So we should focus more on breathing, stimulating breathing and supporting breathing. And last but not least, as soon as you place the mask, it could be, well, in most of the cases, you can induce a trigeminal cardiac reflex. So you need to be very subtle with placement of the mask. So that tells us that actually, yes, we need a table and to provide all the care we would normally also provide on the standard table. So this is what we came from. This is the standard situation, the old situations where we already in the Netherlands came up with cord clamping, delayed cord clamping of 30 to 60 seconds. And the table was actually in a separate room. And as soon as the baby, after 30 to 60 seconds, depending on if the baby was breathing or not, if it was breathing 30 seconds, if it's not breathing 60, if it was not breathing 30 seconds, if it was breathing 60 seconds, clamping the cord, bring the baby to the table, and then do the stabilization. Concord is a resuscitation table what's actually placed close to mom, and it had certain criteria where we took into account when we're developing the Concord table. It has to be placed as close as possible to the birth canal because the umbilical cord can be very short. It has to be, we can provide all the care we normally would also provide. So we don't compromise to the care, respiratory care and the temperature care for the benefits of the cord clamping. And also, but last but not least, we would really have to work together with obstetrician because you're in the same work field. It doesn't need to be, it must not be obtrusive. But not only developing a table, we also had to come up cord clamping criteria, and we call this physiological based cord clamping when the baby was ready. And we had to come up, so when do we think that the long duration has been established, and that also would trigger the increase upon the blood flow. And we based it on 10 years of recordings of respiratory function monitoring and video recordings and oxygen saturation, pulse and heart rate. And we came up with criteria that the baby is stable and breathing. With a heart rate above 100, we could decrease the oxygen need below 40%, while the oxygen saturation above 85. And there's a trial of CPAP before clamping. The minimum time we would use is 3 minutes to complete the placenta transfusion, and the maximum time, because of the temperature management, would be 10 minutes. Then we had to show actually in the first project that it has to be feasible. So we had to demonstrate whether it was feasible using the Concord table to perform PBCC. So using the criteria defined and clamp the cord at that time point while we would provide stabilization and all the support the baby needs. We've shown actually it was feasible. 90% of the cases it was feasible, and I have to tell you that in the cases where it was not feasible, in 3 out of 4 of these infants was because the obstetrician decided they didn't feel comfortable with it. So they also had to get used to it. We started with the larger preterm infants and slowly went down to the more extreme preterm infants. And we actually showed that the cord clamping time was 4.5 minutes. Most infants received respiratory support. There was no increase in pulmonary blood loss, but what was a point of attention was, of course, the temperature, because the babies had a temperature of 36 degrees. And I have to admit that temperature has been an issue in our hospital for preterm infants quite for a long period. So this is not only because of the procedure, but then again, we also were doing this procedure in the OR, where they have the laminar flow and babies can cool down more quickly than when you clamp the cord immediately and bring it to the standard table. If you look on the right, you see the heart rate and oxygen saturation, and the heart rate is more like the proof of the principle that we, with the criteria we defined, are we on the right target? You see that there's, as soon as the baby, the cord is clamped, there's actually no bradycardia. The oxygen saturation was compared to a control group, was actually higher in the PBCC group with using the Concord compared to the standard group, which is an important finding because we know that low oxygen saturation with hypoxia is a marker or associated, that Max Vento, Saxon have been demonstrating that is associated with higher mortality and more IVH. So then we had to take the next step. That was the ABC2. We actually had to demonstrate, is this approach and using the table, is it at least as effective as the stabilization as with the standard approach? So we compared PBCC with DCC, delayed cord clamping 30-60 cent, using the standard table, and PBCC using the Concord table. These were infants below 32 weeks. And we actually showed that there was a non-inferiority study, that it is indeed non-inferior it actually was also, when you look at the time to stabilization, where we analyzed per protocol, that actually it was the stabilization, the moment of stabilization was the primary outcome, was actually sooner stable than when the standard approach. The time of clamping was not different as the ABC1, approximately 5 to 6 minutes. Compared to the disease group, it was 1 plus minus 30 seconds. But also it could be that the time of stabilization soon was due because due to that we could start respiratory support sooner, and that was indeed the case. We were able to start sooner with respiratory support by about 1 minute earlier. We improved the temperature in this infant to 6.5, and there was no difference between the DCC group, and there was again no increase in maternal blood loss, which was important for the obstetricians because umbilical cord clamping was traditionally part of preventing postpartum hemorrhage, which was actually not based on data. So then we had to take the next big step, and that was the ABC3. That was the efficacy trial, where we would like to demonstrate that it had an influence on important outcome. And this is a trial where all 10 centers in the Netherlands, NICU centers, participated. They all had a Concord table. Well, it was introduced, and they were trained, and we started a trial where we compared physiological-based cord clamping with standard care, time-based cord clamping, 30 to 60 seconds, which was already implemented in all units. And we took survival, intact survival, as primary outcome. That was survival without major cerebral injury, IVH more, grade 2 or more, PVL, grade 2 or more, venous infarction, and/or necrotizing enterocolitis, grade 2 or more. We calculated to have an increase in intact survival of 10% in about 660 infants. That was difficult to base it on data we had, but it was also based, of course, on what was possible to do logistically, time related, and that's why we came up with an increased survival of 10%. This is the flow diagram for the inclusion, and I have to tell you that actually with this trial we had to use antenatal consent, so it was not possible to use waiver of deferred consent. It's impossible to enter the room with the Concord table and tell the mother we're going to do it something a little bit differently. And it was a new intervention, so we had to use antenatal consent. But that also lies a problem with antenatal consent because you're creating a selection, because the mothers that came in and where the preterm delivery was very imminent and would happen, these are the ones who are less well prepared, didn't get a time to get the steroids complete course, and you create a selection that you rule out actually the most sick infants. But we had inclusion of 70%. Most of the mothers were actually where the consent was obtained could not be randomized because they reached the point above 30 weeks of gestation. So the obstetrician did a good job on those with those mothers. And we allocated them to DCC and PBCC. And I circled around one of the reasons why we had to exclude the baby or that PBCC was not performed. It was only one time when the umbilical cord was too short, and that proves up that was reassuring for us that the design of the table was correct. So these are the baseline characteristics. As you can see, we had a large proportion of monogoric twins. That's because the center of monogoric twins that was Leiden and actually included a large part of the proportion of the infants. So there's a large proportion of twins and monogoric twins. But also here you can see also the problem with antenatal consent, that the prenatal steroids, almost all babies receive prenatal steroids. The infants, you can see that it was an even distribution between the two groups. A little bit more male than female were included. and there was about half who were born by cesarean, so half who were born by a vaginal. This shows that the randomization went well. So this is the primary outcome, which was, of course, a little bit of disappointment for us. We did show we could demonstrate an increase in tech survival from 67.6% to 71%, but that was not, of course, not near the 10% where we were aiming for. So that was not significant. And if you looked at the different components of the primary outcome, you can see a significant difference between the two groups. We also pre-planned some subgroup analysis because we could perhaps show a difference there, is that the gestational age, the sex, and the mode of birth. And as you can see, if you look at the smaller infants and larger infants, there was again increase in both groups in tech survival, was not significant. But if you look at the male, there was a large increase in tech survival when compared to the standard group, about 8%, and that was significant. So actually in the male, there's a signal that there's a significant increase in tech survival, which is actually not that surprising because we all know that male infants do worse when it comes to prematurity, and they have worse outcome when compared to female preterm infants. But also we know that male infants do worse during transitions. They really struggle more than female infants, and they have lower oxygen saturations, and the breathing effort is less. So that was a finding, and the mode of birth didn't show that there's a difference when you look at vaginal or cesarean section. If we looked at the stabilization at birth, again, we showed that the respiratory support could be started sooner, but also the infant was sooner, 2 minutes sooner stable. And the cord clamping time was not different as the ABC2 trial. We actually showed that actually there was a good protocol adherence, about 5.5 minutes, and the other one, the standard care was 0.47 seconds. There was no difference in respiratory support given, and the 5-minute depth score was also not different. There was a difference in umbilical pH. It was actually lower in the PBCC group, which was actually also not a surprising finding because it has been described before. And it has to do with that the placenta is a rich source for a lactate as energy to provide energy, and this had probably to do that the lactate influences the pH. If we look at the safety parameters, maternal and infant, the maternal, there was no increase in pulmonary blood flow. The postpartum hemorrhages, there was no significant increase. There was no difference. The surgical site infection also, because they were doing cesarean, there was also a concern about that. There was no difference between the two groups. And if you look at the infants, there was no increase in polycythemia, hyperbilirubinemia, and also when you look at the medium admission temperature, still there was 0.4 degrees more hypothermic than when compared to the standard group, which was a small difference, but still it's significant. If we look at the secondary outcome that we pre-specified before we started the trial, the HB increased a little bit, but wasn't significant. But more importantly is that we were able to give less blood transfusions to the infants allocated to BVCC, so that's a win. And we also had a decrease in late onset sepsis, which has also been described before with delayed cord clamping, but with PBCC, even there you get a decrease in late onset sepsis, which is also a discrete outcome. We looked at the IVH grading, that actually had no difference, but there was a difference in post-hemorrhagic ventricular dilation. Actually, it decreased to 1/3 when compared to TBCC group, which is difficult to explain when you have no difference in the grading of IVH, but it could be possible that the difference the grading is not subtle enough to show a difference in how the IVH occurs and how much blood there is. There were no differences in these other secondary outcomes. But one thing that we really learned was about the learning curve. We pre-specified that. We thought maybe the amount of procedures you performed could have influence on your outcome. And this is the odds ratio of PVCC and the number of procedures. So it actually showed the more procedures you would perform, it had a positive influence on intact survival, and actually was significant. And if you look a little bit, is that you see about around 40 procedures, there is a turning point. You might say, well, you know, this is just stabilization and it's under cord dislocation, but apparently there's something into it that standing at a dislocation close to mom, but also keeping the temperature management and provide adequate respiratory support while also keeping an eye on the umbilical cord, because you don't need, you must not stretch the cord or kink the cord. I think that is where the learning experience lies. So this shows you actually, so if you want to do it, actually, you would start off with a larger preterm infants and slowly go down to get more experience. But this also prompted us to do a post-hoc analysis on this data, on the learning curve. And we came up with that. We compared actually Leiden Center and the Erasmus Center in Rotterdam with the other centers. And for the reason is that, well, Leiden was already working on Concord for quite a while because actually we designed it. And it has been implemented for the ABC1, ABC2. We do CDH trials, so congenital, the infants with Erasmus implemented for the CDH trial, congenital diaphragm hernia, and LMC actually used it as already implemented it for standard care above 30 weeks, but also we stabilize infants according to PBC with infants with congenital heart disease. Leiden and Erasmus were the first one who actually started with ABC3. The others started later on. Sometimes some centers post already 2 years after starting the trial, and we were responsible for the large proportion of the inclusions, around 42%. And we also each center had most inclusions, so also more experience. Around 20%, more than 20% were included in each center. And the other centers had one center had 10%, and all the other centers had below 10%, with a range between 1.8 to 7% or 8%. And the other centers, the Concord was bought and implemented for ABC3. They had training, and then they started later on, but the approach was implemented for the trial. So we specified the Leiden and Erasmus as the experienced centers and the other centers as the less experienced centers. If you look at characteristics, you see that the complete course of antenatal steroids, the experienced centers was lower, significantly lower, and that probably has to do that we felt more comfortable including the more sicker infants or the more imminent deliveries. Gestation age was lower, birth was lower, but also the amount of babies stratified below 27 weeks, we included more infants when compared to the less experienced infants. So it could be possible that because we felt more comfortable with the procedure. And if you look at the intact survival between the experienced centers and the less experienced centers, if you look at the experienced centers who were responsible for 43% of the inclusions, you see an increase in intact survival, significant increase from 58 to 71%. If you look at the less experienced centers, it was 74 and went to 71%, and it had no difference. And the low intact survival in the TPC group can be explained that we included lesser preterm infants, less well-prepared infants. We also had, because the center of monoclonal twins was Leiden, which have also worse outcome. So that could be influencing the lower intact survival when compared to less experienced care center. with the standard group. So you actually show here that when you have experience that you can get an increase in intact survival. We also asked the parents what they thought of it. We had a questionnaire with a like it scale, and they actually showed that the parents were actually satisfied or happy with both approaches, but they were more satisfied and less anxious. It felt more safe for parents and for the infant when PPCC was performed. So, in conclusion, what have we learned in the last 10 years? It's been a long 10 years with a lot of people involved, from neonatologists to physiologists, technicians. And the first was, well, we shouldn't see pulmonary and circular transition as two separate things, intricately linked. And there's a good rationale for performing PPC. It really makes sense. Per term infants, when they start crying at birth, healthy term infants, we also wait with cord clamping until they have started breathing and have aerated the lungs. So why don't we provide it also for the infants that need help? PPC is feasible and safe to perform. The stabilization is effective as soon as stable. That's what we have demonstrated. It had no significant impact on the whole intact survival, but it had an impact on the intact survival in male infants. It had an effect on secondary outcomes, which are distinct and matter. I think less blood transfusions and less sepsis do matter. And we now know what parents want. And last but not least, and I think that's the most valuable lesson learned, is that actually perhaps we underestimated the learning effect of the experience you can get once you start doing this. And the lesson we learned is that if you decide to implement this or decide to start doing it, my advice would be to start off with larger preterm infants, get more experience, get more comfortable with the procedure, get more used that you're not only stabilizing infant, but you have to keep an eye on the cord, and then slowly go down to the more extreme preterm infants. I thank you for your attention, and I'm happy to answer all the questions you have. Back to you, Rihanna.
Thank you, Arjan, for this great overview, which has been a lot of work, but also impressive results. Thank you very much. We open the floor for questions for all of you. So we prefer you to ask your question personally if you like, so you can then switch on your camera and switch on your microphone and ask your question. And if you have a question, please use the raise hand function in Zoom. If you don't want to do that, of course, you can also put your question in the chat and I will read it to Arjan to answer. Arjan, can I ask you a first question? So based on this 10 years of experience.
Sorry, Rihanna. Wrong windpipe.
Oh, all right.
Yeah.
Can you explain what you're now doing in Leiden?
Yeah, so based on the results we had a big discussion in our unit and we decided to implement it. We already implemented for vaginal deliveries starting last year, early last year. We actually now still are working on how to implement it in the OR. We first want to have more, re-implementation in vaginal delivery. People get comfortable with it. But we are about to start doing this in the OR for cesareans in February, starting in February. Rotterdam now finally had also the discussion and they decided also to implement it in their unit. Most units, other units are a bit on the fence about it, or they do it vaginally. And there's only one center that decided, well, there's no difference in primary outcome. We're not convinced we should implement it. Right. So these are the reactions of the different centers.
And any idea in total how many babies have been supported on Concord in Leiden University Medical Center? Maybe difficult question.
Well, we already do it above 30 weeks.
Yeah.
So there, yeah, you know, let me put it this way. I can't tell you amount. I think it will be below 30 weeks. It will be about 100 in a year, because that's our
Mm-hmm.
number. Um, um, but let me put it this way. It used to be that during the handover, people would say, this baby has been stabilized on the Concord. Now it's not mentioned anymore, but if the baby stabilized on the standard table, it would be mentioned, because that would be an exception.
Yeah.
Yeah.
Yeah. Very good. Thank you. First question was from Elizabeth Sater. Elizabeth, do you want to ask yourself? You need to unmute. Yeah, there you
Yes,
go.
thank you. Well, it's in the chat, but I
Yeah.
can see, and that's my experience too, that infant temperature control is still a challenge. And I guess it's an overall global challenge. But do you have any plans on how to improve, or what we could do to improve it?
Yeah, thank you for that. So that's an important question. I still have to say that temperature management, as you said, globally, but also in our unit, it was also already a point of attention. But we now starting with a heat mattress that we can place on the Concord and see if that can improve the temperature management. We already do the heat, you know, this has a radiant heater, the head, the wrap. I actually personally find out as soon as the baby stabilizes, especially with cesarean, and you clamp the cord, then you put the babies using heated towels, you can improve the temperature. But I'm looking forward to the heated mattress, see if that's a disposable mattress that you can use. And hopefully that will improve the temperature.
Yeah, and if I can add, in the meantime, there are about 85 hospitals using Concord, and we see that about a third of hospitals that start using or start with this procedure have challenges with temperature management, and we have a big focus now in the implementation and training on the various measures you can take for temperature management, and we see that it is an element that you can improve, but it needs attention and focus. Miriam Kleinhout, you have a question.
Yes, Arjan, thank you for your very nice overview and all your work that you have done with your team. I had a question on the umbilical cord measurement, the pH measurement, because you said it's lower in the Concord babies, and I assume, but I'm not sure, that you measure it after you clamped. Is that true?
Yes, yes. Well, actually, the blood sample has been taken after the cord is clamped. That's indeed the case.
So that's also a difference between the two groups, isn't it? Because the first one would be earlier than, or the non-Concord babies would have an earlier measurement than the Concord babies.
That's true, yes.
Yeah, okay, thank you.
We have Hans Kerner in the audience, also a user of Concord. He has a lot of experience in taking blood gas analysis immediately after birth, also with Concord. I don't know, Hans, are you there, and would you like to say something to that? Yeah, there you go.
Yes, hi. Yeah, we usually do it that way, that we take the blood samples while the babies are still in the cord. We enlist the help of our obstetricians because they have nothing else to do anyways besides stimulating the baby and waiting for us to get ready. And they feel happy just taking small samples of blood directly from the cord, either from the vein or more easily from the arteries with a small cannula. There's no problems with bleedings because these arteries, they close up immediately afterwards, and we get normal pHs and timely pHs from the babies doing it that way. We have done about almost 200 babies that way, and we never had any problems.
All right, thank you, Hans, for sharing that experience. There's another question in the chat from Professor Aladangadi. Professor, do you want to ask your question personally?
No, thank you.
There you go.
I can't remember exactly. I think 70 babies were excluded from the interventional or physiological placenta transfusion arm. I believe it's 11 babies from the delayed cord clamping group. Is, Professor, the result available comparing excluding these babies, or it's only intention to treat?
So could you repeat the question? I didn't get it completely.
What I'm asking is, have you done the analysis excluding those? It's quite a large number, almost like a,
Oh, you mean, did we also per protocol? Yeah, and it actually shows a more increase or a high increase in tech survival, but still not significant. But indeed, that influences the results, but not that much.
Okay, thank you. Thank you.
Okay. Thank you very much for that question. Professor Pratesi, you're also here. Would you like to ask your question yourself?
Okay, thank you.
There you go. Yeah.
And many compliments for the great trial to Professor Tepas. I would like to know if it was very interesting the differentiation of centers by experience, and I would like to know if the timing of cord clamping was different between experienced and not experienced centers.
Yes, thank you for the question. We actually looked at that, and it shows actually in the PPCC group there was no difference in timings.
Okay. Thank you very much for that question. Professor Pratesi, you're also here. Would you like to ask your question yourself?
Okay, thank you.
There you go. Yeah.
And many compliments for the great trial to Professor Tepas. I would like to know if it was very interesting the differentiation of centers by experience, and I would like to know if the timing of cord clamping was different between experienced and not experienced centers.
Yes, thank you for the question. We actually looked at that, and it shows actually in the PPCC group there was no difference in timing. So also the less experienced centers, because you would expect that they will feel less comfortable, they would wait shorter with cord clamping, but actually they stick to the protocol. There was no difference, but there was a difference in the control group. Maybe I saw also Ronnie online. I can't remember. Was it in the less experienced center shorter or longer, the delayed cord clamping, the standard group? Ronnie, can you help me out here?
I think shorter in the less experienced.
Yeah,
yes.
shorter. Yeah.
Yes.
Yeah.
Thank you.
Thank you, Ronnie. Are there any additional questions from anyone in the audience? Any remarks? Elizabeth?
Yes, I've studied a lot of cesarean sections lately during delayed cord clamping, and I was just wondering, did you experience any placenta spontaneously detaching during the PPCC intervention? And I would also like to know what method for placenta delivery was used in the cesarean section, if you can highlight that.
So the first question was about did we experience detached placentas? Yes, we did, but was also most often was with during cesareans when it changed over vaginal labor to an emergency cesarean, but not within 15 minutes. And sometimes the baby was born, but also the placenta was already detached. And the second question was?
I just wonder which method for placenta delivery do you use? Is it up to the obstetrician to decide, or is it any details in the protocol saying how to do it? Spontaneous detachment?
We didn't protocolize it, so we left it to the discretion of the caregiver or the obstetrician. Yeah.
Okay.
So Arjan, can you clarify what would you recommend if the placenta detaches while the baby is still on the cord?
Well, of course, we can take a look and separately analyze it, but there are not many infants. But if you look at the rationale of to do it, waiting with cord clamping, you still can wait with cord clamping until the baby started breathing, because there's still perfusion from the baby going to the placenta and backwards. So you still have the effect of cardiac output. But the only thing that you have lost is that the baby is still provided by oxygen via the mother. So I would still recommend to wait with cord clamping until the baby's ready.
Yeah. All right. Thanks. Another question from Dr. Susanagi. Do you want to ask the question yourself?
Yes, please. Congratulations on your work, Arjan. My question would be that, is that safe to prolong the cord clamping time above 10 minutes of age?
Good question. The honest answer is I don't know, because we haven't investigated it. I know that midwives here in term infants wait for longer than 10 minutes sometimes. I think the circulation would stop at a certain moment, but my honest answer is we haven't investigated this, so we don't know.
Thank
So
you.
would there be any, sorry, yeah, go ahead.
I just wanted to say thank you for the answer. Thank you.
Would there be any reason why we couldn't wait longer, Arjan?
Well, the reason why we take a max of 10 minutes was because of the temperature. And also we thought, well, if you wait longer than 10 minutes, and then you also had really a baby that was really struggling, and we shouldn't wait any longer. But we took the 10 minutes as a max, but that's an artificial limit that we took. So, but I would, based on the data we have, I can't recommend to wait longer.
Yeah.
I think this is the study where we have waited the longest compared to all the other studies. So.
Yeah, true. All right, thanks. Any other question from anyone? So you already addressed a little bit, Arjan, the relevance of experience. So what would you, I will finish this question first. What would you recommend centers who already use Concord or who start using Concord or implementing intact cord resuscitation, physiological based cord clamping?
Well, if you start doing it, I would really recommend start with the larger preterm infants and get some experience, and then slowly go down to the more vulnerable babies. If you're already doing it for like what Hans is doing and included already 200 babies, I don't think I have any recommendations. You actually are ahead of the game. What helped in our unit is that we do the recordings. We record it and we evaluate it and we review it. And we discuss it, how we can improve the procedure. So that would really help.
Yeah, all right. And I remember also from previous discussion that you recommend really to monitor the umbilical cord very well.
Yeah, I think that's an important part that we actually, when I give talks and things, I actually did not emphasize that enough, is that actually when you're doing this stabilization, someone needs to keep an eye on the cord. Well, if Hans has put it nicely, that the obstetricians have nothing to do, so perhaps they can keep eye on the cord so that the cord is not stretched or kinked, or the baby's lying on the cord, because that's an important part of the whole approach.
Yeah. All right, thanks. Stina Klemming, you have a question.
Yes, thank you. Hi. I was wondering if you separated into two groups sort of and looked into it, the babies needing only stabilization, like a nasal CPAP, just very gentle care, and those babies that actually needed resuscitation, ventilation, or other
The honest answer, no, we didn't look at that, but we could take a look, of course, the ones who really needed positive pressure ventilation and the ones needed CPAP. I have to admit that most infants, based on the recordings we make, that most infants that actually receive, I'm talking about Leiden now only, the most infants that receive PPV actually, in retrospect, didn't need PPV because they were already breathing, but it's missed or underestimated by the caregiver. We're pretty trigger happy when it comes to providing inflations. But it would be interesting to look if there's a difference between the two groups. Indeed.
And some units have standard procedure that you start with nasal CPAP only, then you can't do PPV. If you start with actually a mask with the possibility to do PPV, as you say, we're trigger happy. That could be one.
I would love doing that, and I would love to implement it in our unit, but I don't think my colleagues will feel comfortable not being able to provide PPV yet. But that takes time, and
there are new devices where you have both. So yeah.
Well, we also have both. We can provide CPAP.
Yeah, but the RPAP. I was thinking about the RPAP.
Yeah, but the neopaf can also provide CPAP and PPV. So yeah.
And also another question: where did the babies go after stabilization? So did they go to skin, or did they go to incubator or an open table? And because this really has impact on the temperature.
Yeah. I can understand that there are all kind of pioneers here in this meeting, and I would love to hear about your experience. We are working on getting on the next phase and getting skin to skin after stabilization. But so far, that's the advantage of the table, at least, is that you can keep the baby close to mom. But we haven't had any experience with skin to skin yet, but that's the next phase to implement it in a safe and effective manner.
Thanks.
Thank you, Stina. There is an additional question of Simone Pratesi.
Yes, thanks. I would like to know if you have some ideas about how to improve the adherence rate to protocol. For example, in cesarean section, urgent cesarean section. And also,
yeah, very good question. And that's, of course, that we have been discussing. And what we now came up with, well, for the vaginal deliveries, we are about to implement a table so that the table is standing ready in the room. So that's when there's imminent delivery, because sometimes you miss out. You can immediately stabilize the infants on the Concord. And for the we're discussing with the OR that the table has a fixed spot in the OR, standing ready, and in that way, it would increase our possibility to also stabilize infants when there's an urgent cesarean.
More centers do that, which seems to be a good solution.
Yeah.
Miriam.
Yeah, I was wondering if you have any experience already with heated air, or do you use as
we use heated humidified air, but that's standard care in our unit.
And is that was that in all the other units as well?
Not in all units, and I have to admit I forgot to mention that the more experienced centers have better temperature management than the less experienced centers, but it could be due to the heated humidified air, but could also be due to the experience you have.
We also advise to use the humidifier and warm air because also air from the wall or from cylinders is really cold. So when you ventilate with the cold air, it may affect temperature. So using a humidifier is a good temperature management measure.
If I may add, we used it humidified and heated as well from the beginning, and we never had any issue with temperature problems with the small.
Yeah, good addition. Thank you. There's one question from Sabrina Sladek. She doesn't have a microphone, so I will read it for her. The gynecologist told them that mothers have a higher blood loss in C-sections when they use Concord. do your gynecologist use any operative measures to stop the bleeding while waiting for the for the cord clamping?
Yeah, they use these clamps for the vessels that are in the uterus that starts to bleed. They clamp it, and that's what they use. But they feel very comfortable. And as you can see in the trial, there's no difference. And also, if you look at the cesareans, we sub-analyze, you don't see an increase of blood loss. So, well, it could be the gynecologist tells you, but I would prefer to have it measured.
Yeah, good point. A question from Richard. Richard, do you want to ask your question yourself? Yes.
Yes, thank you. Great talk. What's your, there's three things actually. One, do you use plastic bags to put the baby in at delivery for temperature control? Two, what's your experience in babies less than 25 weeks, or the 23, 24 weekers, who are the ones that are the most difficult to transition and have the highest rate of IVHs? And I would have thought this process would be of most benefit to them. And do you do a subgroup analysis of that group as opposed to less than 27-week gestation babies?
That's a very good idea. We haven't done it yet. We can do it. And plastic bags, yes, we use plastic bags, a wrap. And we don't have any experience below 24 weeks, but perhaps Hans can talk you about his experience in less than 24 weeks. Hans, do you do less than 24 weeks?
Yes, we do. Not very often, but we do it, and we use plastic bags the same as you do. Actually, we decided to do it the way you do it, with just using it like a rain poncho with a hole inside, and so it's very easy to use it for the babies. And we didn't have any problems with the plastic bags. The addition of the radiant heater, the plastic bags, and the heated humidified air, I think that does it. The combination of these things. Of course, our operation room is the surgical theater is heated as well, as is the room where we do the rest of the stabilization. So yeah, I think using plastic bags is the way to go.
Yeah. Can I just ask another question?
Sure.
Just about post-hemorrhagic ventricular dilatation, there was a sort of difference between those. I just wonder whether that's maybe a better outcome than grade 2 or 3 IVH. It's very difficult sometimes to distinguish between grades 2 and 3. I mean, what you're interested in is the consequences of the bleed. And post-hemorrhagic ventricular dilatation seems to be a reasonable consequence rather than a bleed that doesn't dilate up.
Yeah, I completely agree.
Yeah,
I think it's a more important outcome than the grading of the IVH, because if you if you tell parents that it had IVH grades 2 or 3, you tell them, well, the consequence could be that there's going to be a dilatation with all the kind of interventions you need, and that's actually the real consequence. So I agree, but
would that alter your outcome?
If you include the post-traumatic, we didn't do that.
Rather grade 3, rather than grade 3.
But the incidence is very low, of course. But we could do it. We could add it and see what the outcome is. But that's actually what we didn't do in the pre-planned analysis protocol. So, but we could do it post hoc. Yeah, that would be interesting.
Mm-hmm.
Thank you.
Thanks,
Thank you,
Richard. So one last question before we close the meeting from Professor Szabo, Miklo Szabo. I see you. So do you want to ask your question yourself? Yes.
Yeah, yes, of course. Congratulations for the extreme nice work. But of course, we were expecting that 0 IVH would happen in the physiologically based cord clamping group. And this was not the case. So, Arjan, do you think that physiologically based cord clamping is currently an optimal to protect babies completely from the early perturbation of cardiovascular adaptation? And if yes, then do you think that these results teach us that if we are able to protect the babies from the early variation of, then what kind of factors produce IVH in this group?
Come on, Miklos. I can't give a lecture of 2 hours about all the factors that are influencing when there is an IVH occurring. I think we know that these babies are very vulnerable for susceptible for these large swings in blood pressures and blood flow. That's why we came up with the rationale to look at IVH. But of course, you know, the cord clamping in the first 10 minutes is not the only reason or the only factors that influence IVH. I completely agree with you. There's several other factors, antenatal and postnatal. But we would have expected at least some decrease in IVH. So when you say, well, we would expect 0% of IVH, well, then I would be a dreamer. Thank you, Miklos.
But Arjan, did you see a reduction in IVH in the experienced group, in the experienced centers?
Ooh,
okay.
I don't have the numbers in my head yet. Ronnie, help me out here.
No.
I think it's more mortality.
Yeah, all right.
Was it? Yeah, it was more mortality than IVH or neck. You have a decrease in IVH in neck, but that was not significant. But the most important decrease was in mortality.
All right. Okay. Thank you.
That experience, as I showed before, we have a sheer drop in mortality and less severe hemorrhages. We still have hemorrhages intraventricular, but they are less severe.
Yes, thank you, Hans. And you've shared with us the results in your specific center, and we'll for sure organize a Concord Talk for you to share your experience and your amazing results from your center in another Concord Talk in a couple of months, probably.
And publish it.
Yeah, that's a good idea. So that concludes today's Concord Talk. Thank you very much, Arjan, for a great talk and all the work that you've done and the cooperation we've had during these past years. Thank you everyone for joining this talk and for great discussions and all the questions that you've asked. For us, this feels like the beginning, although we have been working on this for 8 years, with a lot more to come and a lot more data to share this year and upcoming years. So thank you very much. If you have any additional questions, would like to talk more or would like to discuss, contact us at join@concordneonatal.com, and hope to see you soon or in the next Concord Talk. Thank you very much.
Thank you, Rihanna. Bye-bye.
Thank you, Arjan.
Bye.
Bye, thank you.